Good evening and welcome to the Health and Adult Social Care Overview and Scrutiny Committee, today the 26th of September 2022. Welcome to all the members and officers that are in the room and visitors, and to all those that are joining us online as well. Our clerk tonight is Louise Smith from Democratic Services. And Louise, would you like to go through the housekeeping notice, please?
Certainly. Please note that this meeting is being recorded for live broadcast and will be published on the Council website for a minimum of 6 months. Please could everyone present please follow these ground rules. Only speak when invited by the Chair. For those present in the meeting room, please use the microphones on your desk when speaking. If accessing the meeting via Teams, please turn on your video function before speaking. Again, if you're accessing via Teams and would like to speak on an item, please do so by utilising the Raise Your Hand feature in the bar at the top of the Teams window. For those in the room, please note that if a fire alarm sounds, please exit the building by way of the nearest available signed fire exit route and make your way to the assembly point along Braidley Road under the flyover. And finally, please ensure background noise is kept to a minimum and mobile phones and other devices are turned off or switched to silent for the duration of the meeting. Thank you.
Thank you, Louise. Would you like to now move on to agenda item 1, apologies, and agenda item 2, substitute members, please?
Apologies have been received from Councillor Robson and Dion, and Councillor Tony Trent is substituting for Councillor Robson.
Thank you. Agenda item 3, declarations of interest. Do we have any committee members with declarations of any interest? Councillor Evans.
Thank you, Chair. For transparency, I'm a bank employee of University Hospitals Dorset.
Thank you. And Councillor Johnson?
Thank you, Chair. I'm employed by Universities Hospital Dorset.
And Councillor Matthews? Thank you. Moving on to agenda item 4, the confirmation of minutes. Do we all agree to the minutes from the meeting held on the 25th of July 2022 as an accurate record? Agreed? Okay, thank you very much. Okay, thank you, Councillor Trent. Agenda item 5, public issues. Have we got any public issues for this meeting?
No, Chair.
Moving on to agenda item. Sorry, Karen.
Sorry, Chair. On the minutes of the last meeting, I'm obviously remote, but not recorded as being there, and neither is Councillor Jane Kelly. And I wondered if we should have been included. Thank you.
Thank you, Councillor Rampton. Agenda item 6, the action sheet. Do you all have the action sheet plan in front of you? We got any comments to make on this? Anybody online? No. Okay, we'll leave that one as it is. So agenda item 7, which is the maternity services update and clinical service review update, including building works at Poole Hospital and the Royal Bournemouth Hospital. So can I call upon Richard Renaud, Chief Strategy and Transformation Officer at the UHD NHS FT. I'm sure we all know what all that stands for. And then Kerry Taylor, Head of Midwifery, who will provide an update on the maternity services. So, Richard, did you want to go first? Thank you.
Thank you, Chair. Thank you for having us at the meeting. Our intention is for me to speak for about 5 minutes, and then Kerry, who's our Head of Midwifery, to speak about 5 minutes to pick up the items that you just mentioned. So I have a couple of slides to guide us. If that's okay, I'll share those. And then if it's possible to take the questions, if there's any questions, discussions at the end of the presentations would be helpful. Thank you. Just check the... Great, thank you. That's working, right. So, okay, so this is just a quick reminder that we had the clinical service review across Dorset, across particularly health, but also social care, and a lot of work just recapped there, which I won't go into detail, but was about the need for change the engagement, consultation, judicial review, which was a sort of several-year process that completed in 2019. And the key to the clinical services review is prevention at scale, integrated primary and community services, mental health pathways, and one acute network for hospitals. It's on that last item we're sort of dwell on a bit more today. And that was around the creating major planned hospital at Poole, an emergency hospital at Bournemouth, Royal Bournemouth Hospital, and that work is now started, the physical building work started. And to make that process work better and to better integrate services, we merged the hospitals in October 2020, so come up to 2 years now, similar timescale to the council. We then obviously had the pandemic, and we're here now today to just bring you on the next stage of the journey. In terms of the benefits of clinical service review, just a quick recap, but around the planned hospital, really focusing on elective care, uninterrupted, particularly by emergency pressures, which both the pandemic and winter and now often throughout the year is a real issue for getting patients in and treated who don't have emergency but do have that important need for elective care. But also on the Poole site, remaining a UTC, that's an urgent treatment centre, open 24/7. On the emergency site, full range of emergency services, whereas at the moment many of those services are split, either only on Bournemouth or only on Poole. So it would improve access and speed of care. And without rehearsing all of the debates over several years, that was the conclusion of the independent review panel and and judicial review process. So overall, we will have better facilities and environments for patients, and we'll talk a little bit about that in the maternity section in a minute, but also it'd be much more attractive for staff to work in because they serve to be more sustainable in better facilities, are already seeing benefits in research and development in practice because of our ability to focus in the way that hospitals will do. And we've also got other services joining up around information sharing, coordination with teams, particularly primary GP services, and pathology services, which I'll show you in a second as well. So that's in a nutshell why we're doing this. If any of you have driven near Poole Hospital or Bournemouth Hospital recently, you might have seen the cranes up. So there's a lot of work going on at the moment. Pleased to say on time and on budget, despite COVID and energy and inflation issues. And the Poole, the first phase of that will open in next spring, and Poole Theatres, we see benefits of that next year. The beach building, as you can see, named for a staff competition about people wanting to work on the beach, but it also represents births, emergency department, antenatal, critical care and child health. That will open at the end of 2024, so that's 2 years away. So whilst the building frame is going up rapidly at the moment, almost every week you see a new section being added, that is as it will complete in 2 years because the amount of fit out. That will give us an ED department double the size of the combined ED departments, a new critical care unit. So, also, but less visible, is building a new pathology hub, which is on the Wessex Field site, which working with BCP Council, we've created that opportunity, and that will bring together really cutting edge technology, the staffing expertise in purpose-built facilities, and that's very exciting. Will open next summer. And you see on the right-hand side that the steel frames are up for that as well. I won't spend too long on this, but the Poole Hospital site, this just gives an idea of the refurbishment works, but at the top end here is where the theatres are, where you can see are largely complete now. We're now doing the internal fit out. But over the next 4 to 5 years, there'll be significant amounts of refurbishment throughout the site and remove a lot of the backlog maintenance, as well as making it a planned hospital with dedicated internal changes. Very significant investment. And then on the Bournemouth site, this is looking sort of bird's eye view, but the most significant bit is the beach building here, which is a significant new build in the corner, bottom corner of the site. The lake is in the middle there. Refurbishments around quite a lot of the sites to make it a modern, fit for purpose, well-designed emergency hospital. And then a further 5-storey building here, which will be where our catering department is, and that will also include us rebuilding and improving our food offer, as well as new inpatient wards. The pathology labs here on the edge of Wessex Fields, and this is the road link to the hospital, completing the junction onto the Wessex Way. So I appreciate I'm going at speed, but obviously if there are questions, please pick them up. But I'll hand over now to Kelly, if that's all right.
Hello, so my name is Kerry Taylor. I'm the newly appointed Head of Midwifery. I started at UHD in April this year. I've been a midwife for 22 years, but spent most of my career working in Reading at the Royal Berkshire Hospital. And I have been really wonderfully embraced by UHD. So I'm delighted to live by the seaside and be part of the new team. The Head of Midwifery is a new role. It places me perfectly between the Director of Midwifery and the rest of the senior team, so enables me to really focus on the operational running of the maternity department, as well as having a good insight into the strategic direction of the maternity services. So I just wanted to give you a bit of a whistle-stop tour of maternity at the moment at UHD. So currently, in the last year, we've had 4,086 births. That's approximately 11 per day. I wish I could give you an update. Apparently today is the busiest day to have a baby, but I don't yet have the numbers for today's birth rate. It hasn't finished. We do know that that number has decreased over the last year. We normally sit at about 4,500 births a year, so we're just waiting to see whether this is a local change or more of a national change in birth rate. Modes of delivery at UHD, we're proud to say that we do still have a 2% home birth rate. That is national average, but we did used to have a home birth rate as high as 4 to 5%. 11% of our babies are born on our Haven Birth Centre. We have a 54% normal birth rate, 13% instrumental delivery rate, and a 33% caesarean section rate. I'm sure you're aware that there is a lot of encouragement now for maternity units nationally to not measure their success on their caesarean section rate. But what we wanted you to know was that actually we are sat well within the normal levels of what we would expect for each mode of birth. Nationally, we are seeing a rise in inductions, with 43% of our ladies being induced at UHD. And that's because we are nowadays listening much more to what our women would like and working with them to put in a care plan that suits their needs as well. We're really pleased to say that our number of term babies admitted to NICU is better than the target set locally and nationally. And HSIB, our Healthcare Service Investigation Branch, have no concerns with UHD at all, and we have no current cases open. 80% of our babies initiate breastfeeding within 48 hours, and we have a plan to try and achieve baby-friendly accreditation within the next year. Looking at national policies, I'm sure you're all familiar with the Ockenden recommendations, and the first part of our review has been completed. That was the Ockenden 7 essential actions. We have an insight visit planned early next month with the regional chief midwife, just to ensure that we are fully compliant with those.
Sorry, Kerry, can I just interrupt you for 1 second? I don't know what an Ockenden recommendation is. I don't know if anybody else in the room does.
Okay, sorry.
If you wouldn't mind just explaining for us, thank you.
Happy to. So Donna Ockenden was asked to lead an inquiry into the Shrewsbury and Telford Trust, where there had been over a number of years some very poor outcomes within maternity. She launched about 2 years ago 7 immediate and essential actions that all trusts had to immediately implement, and we are being held to account for those quite rightly. And the insight visits are just to review where we are with those actions. She then updated her report when that was completed, and there are another 15 essential actions with 92 individual steps. They've put a pause on that piece of work at the moment, but it will be reignited at any point. And we're actually progressing quite well with that. So although the rest of the country has kind of stepped still for the moment, we've continued to make sure that UHD is moving in the right direction. And we're on track with 9 of those 15 actions being already green and 6 of them being amber when we RAG rate them. So it's just really to give you assurances that we are following the national recommendations to ensure our maternity unit is as safe as possible. One of the findings from Ockenden was the pursuit of normal birth at any cost was detrimental to women and babies' well-being, which is why caesarean sections are no longer measured as a level of your success as a maternity unit. Continuity of carer has hit the news last week. So this is a national drive to try and encourage all maternity units to ensure that women are cared for by a team of midwives that they know at every stage of the journey. So they are to provide interpartum care as well. This is quite a challenging model to implement, and there have been questions raised by Donna Ockenden about the safety of this model of care. And so last week there was a national suspension on this way of working until staffing was safe within maternity units. Our Director of Midwifery had already foreseen this and actually had been very slow to make continuity of care happen because of her concerns about staffing. So at UHD we haven't yet launched any continuity of care teams. However, we would like to move towards pursuing that in the new year, because the beauty of continuity of carer is that it enables our most deprived ladies to have the step up and the support they need to have safer care. So we hope that our staffing will improve in the next few months. We have good plans for that, and when we're ready, we will launch our first team. Moving on to COVID restrictions. People often think that maternity wasn't very affected by COVID, but it absolutely was. We found that our BAME community were really at risk with COVID. We had already challenging staffing situations, which with COVID sickness for staff as well, made our services really challenging. But we are getting back on track now. So we are returning to normal practice as much as we would hope. Moving on to some of our challenges. So I've already mentioned the staffing. I'm sure you will have heard in the news that nationally there is a massive shortage of midwives, and we are no different here. And we're very excited to say that we have 10 new midwives due to join us early October. We have also some issues with our doctor vacancies, and we've seen amazing teamwork over the summer to help to ease those pressures. Sorry, it's not doctor vacancies, it's more doctor sickness and maternity leave that's been the problem. From a midwifery recruitment point of view, we're hoping to have some funding which will enable us to explore the recruitment of internationally educated midwives. This is something I did successfully in my previous trust and is really the answer to a lot of our staffing concerns. And also we're very excited to be looking at utilising nurses within midwifery, because there is very much a place for their support. And we hope to recruit a retention and recruitment midwife as well. Our home birth provision has been a challenge because of our staffing situation, and also because of concerns with SWAST being able to provide support to us in emergency situations. But we've worked really well as a trust and with SWAST to ensure that twice a day we can actually risk assess and determine whether it is safe to continue offering our home birth service. And that's why we've been able to maintain a 2% home birth rate. Complaints and compliments, we have roughly 3 complaints a month, and these are usually able to be resolved with early resolution, and they're generally around the themes of communication and delays in care. So where we have such a high induction rate, it can be a challenge to move women through the service in a timely manner. Friends and family responses, we had 408 in July, and we had a really good response rate with women, 89.7% of them rating our service as either good or excellent. We do struggle with our building limitations. If you have a chance ever to walk around the Poole maternity site, you'll see that it is falling apart and ancient and tiny for the volume of ladies that we provide care for. And so we are feeling very excited about the new unit opening. There's a lot of excitement and buzz with the staff about moving to a new venue. And when we speak to our ladies about it, they also seem pleased that eventually our services will be nicer. And we have already started the exciting move towards the future. That's fine. Because our antenatal service just a few literally a week ago, moved over to the pool site until we were all able to move back to the beach building. And that's gone really, really well. The benefit of them being over with the rest of the maternity department means that our ladies can have a really safe and timely service with us all being placed in one building and uniting us as a team. And I think that's the end of my story.
Thank you very much. Yes. Anybody got any questions? Councillor Jones.
Yeah, thank you, Chair. You mentioned in your presentation about the national and local shortage of midwives. What's actually been done within the industry to try and address that as a whole? And just following on from that, you mentioned about 10 new midwives joining it on October, which is fantastic. I just wondered how far away you were from the optimum level where you actually need to be in terms of being fully staffed.
Yes, so there is national work on this. So everything from our trade unions working with us to have a Together for You campaign, making sure that our staff, when they're on duty, are well looked after. The retention of midwives at the moment is a massive area of focus nationally and locally. Our unions have tracked where the biggest fall of staff is, and it is for our newly qualified, who will often leave the service 2 years qualified. We have a big fall off of midwives, and also for our midwives who are able to take their pension early still. So a lot of midwives who could work until they were 60 plus are choosing to take the option to go at 55. So there's lots of work and plans on how we can improve working for both work streams. So a really robust preceptorship programme. We have fantastic reviews about our preceptorship programme, and it's been the reason why some of these 10 midwives have actually travelled out of their area where they trained to come and work for us. We're trying to put in excellent pathways for them for their development. So for the new 10 that are joining us, we've planned a 21-month fantastic opportunity to trial everything as a newly qualified midwife before they start to commit as to where they would like to work. And from our older generation midwives, just across the country, they're starting to introduce roles called legacy midwives. So where you enter the back of your career and you're starting to maybe struggle with working night shifts and long shifts, actually the opportunity to become part of the practice development team and support the junior midwives coming through, we hope that that will help to give them a little bit more purpose with their role, change the way that they work, and enable them to support our more junior midwives. We also have a professional midwifery advocate. We're very lucky at UHD that she actually works full-time just in that role. So any of our midwives that are struggling can literally just go and knock on her door or email her, and she will provide them with the support they need and signposts to them. And we're very fortunate because many trusts actually only allocate a few people a couple of hours a week to offer that service, but this is a full-time midwife who is available more often than not to be able to help our struggling staff. I could go on. There are so many things that we're doing to try and to help.
Yeah, sounds fantastic. And also, I just wonder about the number of agency staff have you got? Well, you've got sort of a fairly sort of high turnover of those.
Yes, so we need to have a new birth rate plus review completed so we can properly establish exactly how many midwives we need. But at the moment, we have about an 18% vacancy. But that is only because we haven't counted the new starters coming yet, because they're not in the building. We are also hoping to appoint 12 internationally educated midwives as we go into the new year. And then also we're hoping to appoint about 6 whole-time equivalent nurses, which will help as well. Yes.
Councillor Deadman, do you have a question?
Thank you, Chairman. Well, it sort of follows on from that, I can't think how you put it, the internationally, the midwives coming from abroad is what I'm trying to get at. Where are they going to live though? Because I do know that used to be a problem with carers.
Initially, when they join us, they are given a certain amount of free accommodation until they're able to get settled in. And then what we're going to do, we've already fantastically recruited our internationally educated nurses, and so we're going to be linking in with them for peer support, and we haven't had any concerns raised. I know they're looking at extending the amount of time that our new recruits can stay in the nursing accommodation, but it will only be free for the same amount of time, but they could then pay for it for a little bit longer. We're just trying to work through that process.
That was more of an aside, really. I wanted two things I wanted to ask. Well, one thing I wanted to say, really brilliant, 80% of babies take up breastfeeding, which I think is absolutely brilliant. I really think that's a wonderful total, especially nowadays when bottles are so easy, so I'm told. But baby-friendly accreditation, I'm not sure what that is. Are the babies not normally...
This is the National Infant Feeding Institute that measures the success of all maternity units. So it's like a gold badge that every maternity unit would like to prove that you are experts in offering feeding support. So we do need to do some work on, that's great that our babies are feeding within 48 hours, but the drop off at the point the community midwives say goodbye, and the drop off at the point that they go home from the hospital is quite significant, and then the drop off at the point we discharge to the health visitors is quite significant. So we need to do some work there. It's very hard to gain baby-friendly accreditation, and once we achieve that, you will know that we are absolute experts. It requires everybody to be offering the same advice, and is quite a challenge.
Thank you. Councillor Johnson.
Thank you, Chair. Did I hear you correctly? You said that all the staff from Bournemouth are working in Poole at the moment.
So the staff that worked in the antenatal clinic are now based at Poole with us, but obviously we still have community midwives who are at various hubs throughout the whole of our patch, right from Highclere right the way through, offering community services, which is where most of our ladies have their antenatal care out in the community still.
Okay, and you said they're all going to go back to Bournemouth when the beach building's complete. Is that right?
Yes, but again, our community midwives will remain out in the community providing antenatal and postnatal care for our ladies.
Do you have 12-hour shifts?
We do. We have a mixture. So we have 12-hour shifts mainly in the unit, and our community midwives often work 9 hours.
Because I was wondering if the girls that have moved, or girls and boys that have moved from Bournemouth, do they find it difficult to get to Poole to start a 12-hour shift?
We have a wonderful relationship here with the Royal College of Midwives. Again, UHD have been very kind and invested in one of our midwives doing her RCM work for 15 hours a week, which means she is aware of every change that we ever try to implement to make sure that we do that fairly to staff, and is able to access and help with any of their issues straight away. So she's worked really closely with us to make sure that our staff actually are given the opportunity. They are basically paid to drive to work, so that it was a change that was enforced upon them because we had to move sites, but we've made sure that they haven't suffered for that. So we've given them local parking on the doorstep, and that we're making sure that the time that it would have taken them to travel for work that they never used to have to do is added onto their hours at the end of the month.
And what about the ones that catch the bus?
I believe that's all covered, isn't it?
Yeah. For the 10 staff affected also, then the individual travel plans have been put in place. So I don't believe any are, but I can double check that. But effectively, because it was individual, you say every person discussed what their travel to work would be. So I don't think there was a bus route, but we are looking to try and get a bus route between the two hostels. There's a faster service, so that bus routes exist, but we're trying to work to make that a shorter, quicker route. We were in discussions with the bus companies. Obviously, they've gone through a bit of change, so we'll be re-engaging with them and planning that route particularly for when the larger service changes happen.
Thank you.
Thank you. Presumably, when you all move over to Bournemouth, you'll have to review all the travel plans again. Councillor Evans.
Thank you for your presentation. That's really interesting and obviously very exciting to see how things are going to be in future. What concerns me is how things are at the moment. I believe, having read in the Echo a couple of weeks ago, all maternity services, as you say, have moved over to pool. Having worked in St Mary's, I know it's quite a small, pokey and getting even more and more out of date, that building. How are you ensuring safety and a good experience for our mothers in the meantime?
So a lot of work has been done to try and make as much space as we can within the waiting area. I've been there this week and been in to see the team and see how they're settling in. And actually, the flow through the department seemed to be working really well. It's still early stages. We haven't even had 10 shifts there yet, but initial impressions look really good. We are trying to sort out some vending machines so that people can have some snacks. That's been a little bit of, we've run out of some space to make having some of those luxuries within the facility easy, a bit of a challenge, but we've had meetings today to try and navigate what that could look like. We haven't had any complaints come through to us as yet, and from a security point of view, we have a security officer on the door making sure that they are observing the people entering our maternity department. Did that answer your question? But I think Richard could probably add more.
Just to add to that as well, we did do some building works, although we knew it was only for 2 years. It was to create the additional space needed, and the advantage of putting the two antenatal services together is particularly when there's any complications or risk issues, they can be discussed immediately with senior sort of clinicians, particularly the sort of medical staff, which previously, if you were in Bournemouth, was less, it took longer. It could even be another follow-up visit, so you had all the anxiety between the two. Having them together not only means that we've got a more resilient service, but the physical space has been increased because some of the note stores and admin areas have been converted to clinic space. So there is more space as a result, but it is still tiny compared to what we're going to move into in 2 years' time, which is the properly designed modern standards.
Councillor Matthews.
Thanks. I'll put my microphone on. Excellent presentation, Kerry. It's a very quick question, really. In terms of the baby-friendly accreditation, presumably that sort of the immediate environmental kind of factors are kind of linked to that. So I'm just presumably it will make life easier to achieve that with the move.
Definitely. I think one of the really lovely benefits of the move will be enabling our postnatal ladies to have more space for themselves. That's been one of our biggest challenges in the maternity department, and one of the areas where we probably receive the most criticism at the moment for is actually not being able to enable partners to stay overnight because we just genuinely don't have the space. If anybody would like to come and see how cramped our postnatal wards are, you're very welcome to come and have a look. So, and that pains us to actually make that decision. That's not what we would choose to do at all. I am very keen that as a trust that we move forward to supporting partners with that role of parenthood, but just the facility doesn't enable us to do that well at all at the moment. And it is so exciting that when we move to the new building, most of our ladies, unless for a medical reason need to be in a bay, they'll have their own space, which will make offering feeding support better, which will mean that partners can stay over. They can receive all those feeding messages so that when they go home with their newborn baby, if mum's tired and she's missed some of those messages, partner will remember and be able to reinforce. So the future looks good. It's just a challenge trying to get between where we are now and then. And the staff are so dedicated. We get wonderful letters of compliments and feedback about the service they're offering, but they are really doing it in difficult circumstances.
Thank you. Richard, could I just ask you, you mentioned the new theatres at the Pool Hospital. Are they all fully functional now? Have they all been built, and how many new ones did we have? And do we have any staffing issues with that? Have we had to recruit a lot more staff, and have we managed to do that?
Thank you. So the new theatres open next April, so it'll be spring next year they open. The first phase will be 4 theatres opening, which will move the trauma service, that's the sort of broken bones, into those. And the next phase won't be until the end of 2024, early 2025, when another 4 theatres will be available to open. So it's phased, and that's partly because we're having to make changes internal to the existing building. In terms of staffing in theatres, that is a challenging area. I mean, it is across health and social care. Most areas are struggling to recruit. So international recruitment, again, being looked at there. Lots of investment, as Kerry said, similar stories about how do we support staff, particularly many of those staff through COVID were working in intensive care units as well. So there's a lot of things we're doing to try and retain staff, and at both ends, both new starters staying on, and also some more mature staff, where workload, pension issues, lots of issues of needing early retirement is quite attractive. So a range of issues we're working on there. But at this stage, we say part of our recruitment will be working in modern facilities. Again, the pool theatres are again very cramped. They were designed in the 1950s, opened in the 1960s. They're just incomparable to the new ones that are opening. Those theatres in Poole will be state of the art. So that we think will make it a lot more attractive, and there will also be more support space for staff. But basically things like staff rooms, changing rooms, things like that, which are very cramped at the moment.
Thank you. So, Councillor Butler.
Yes, thank you. I just wanted to ask if people are qualified general nurses, how long would it take to train to become a midwife?
Unfortunately, many trusts stopped the shortened programme a few years ago. You could do that within 18 months, but many trusts aren't supporting that anymore because the retention rate of those staff members was really low. It was quite an investment, and then generally they would go back to nursing. So as far as I'm aware, for most people it will be a 3-year course again. And that's why actually there is a place for nursing within midwifery. They can't do the delivering baby bits, but they can add a massive amount of support by working with us, with our HDU ladies, our high dependency ladies, or coming in and working on the postnatal wards and providing post-operative care to our ladies who've had cesarean sections, and taking the pressures off of the midwives for things like giving baby and mum IVs, by doing the drug rounds, and by doing all of the observations. So we're really excited to move towards that way of working. I did it in my previous trust and it worked really, really well. They were a part of our team that were highly valued.
Thank you. Councillor Evans, did you have a question?
Thank you. Question for Richard. I was involved in the CSR, but it seems many, many years ago now, and things have changed so much. Are we still confident we're going to have the capacity we need for residents of BCP when all these new facilities come online?
Yes, it does seem a long time ago. So starting 2014, completed 2019, then obviously we had COVID in between. In terms of the basic premise of emergency and elective care being split, I think that's been absolutely reinforced as a result of the pandemic. And we actually visited a hospital system in Gwent in Wales, where they did that just at the beginning of the COVID pandemic, and they were able to keep operating, running those services all the way through the pandemic. So I think the basic model's correct. In terms of, is the capacity right? We do know at this stage we have around 250, it varies between 220 and 260, but around 200 and plus patients who are medically ready for discharge, who are not benefiting from, actually are at risk of harm from being inside a hospital, when rehabilitation at home or in a community setting would be better. If we don't resolve that, your point earlier about that's a problem now, that's not good now, we should be resolving it now. But if we don't make progress on that, then there is a risk that we'll be running at the same occupancy levels as we are today, which is too high. So we built all the plans and the buildings aiming for an 88% occupancy rate. We're currently running near a 98%, which means there's absolutely no wiggle room. One of the issues that creates is that getting you the bed in the right time, the right specialty, is virtually impossible. So every day is a sort of jigsaw puzzle to get patients in, and as a result, ambulance handovers take longer. So the whole system's snarled up. So the answer is we've probably got enough physical beds. If we had more, we'd struggle to staff them anyway. But there's not much point building and staffing a hospital facility for patients who shouldn't be there. That would be kind of designing in failure. So that remains a risk. And the contingency there is really to make sure our plans today, working with colleagues, it's about making sure that at the front door, the services work really, really well, and we don't admit people who don't need to be admitted, and then the overall process works better. But by combining on the Bournemouth side, same-day emergency care, as you'll probably know, that makes a huge difference if we can get all of the expertise and diagnostics done in the first 12 to 24 hours. That often was taking 3 or 4 days. And I think a bit like in day surgery, 20 years, 30 years ago even, made a huge difference to elective care. I think day of emergency admission work will make a huge difference. And so one of the big design changes since the CSR is actually to have much larger same-day emergency care units, because we think most patients will get all of their care decisions, senior expert input, diagnostics in that first 24 hours, and that will mean, particularly for frail elderly and other conditions, actually being admitted is then less likely, and you're actually home and supported the same day.
Anybody else? Councillor Debnam.
Well, I think I heard the words, Richard, here when you were talking about the hospital, improving the food offer. I sort of
Yes.
thought that.
Yes.
And I thought, oh, that would be good.
Yes. Yes.
So, yeah, you think that will be part of it?
Yeah, yes, it would definitely. Sorry, yes, it would definitely be part of it. So one of the changes we're looking to make next year is to build a new kitchen facility that will use fresh ingredients and effectively batch cook en masse for the hospital. So at the moment we have to put meals on plates and serve it up for 500 people in one go. It's an incredibly difficult service to offer choice, and also we have quite a lot of food wastage as a result. So the batch cooking effectively would mean we cook, we freeze and use within sort of 3 to 8 days. So we're not using preservatives or anything like that. It won't be at all like a ready meal or anything like that. It'd be fresh cooking, frozen, and then that allows people to choose for a much wider menu, and hopefully that'll be more attractive as well, and also menu size, portion size, sorry. So we think that as a result of that, we continue to offer solid accreditation, good quality food, which we do at the moment, but by moving to that model, which is a large part of our investment, that it just allows us to provide that service on the wall. So we're currently trialling volunteers and staff serving some of those as pilot meals.
I think that's everybody. Yep. Okay. Thank you very much, Richard. Thank you, Kerry, for a very interesting presentation there. Thank you for coming along tonight. I think we can now move on to agenda item 8, which is the business case for the future of care technology with adult social care. And I believe Emma Senior, the Commissioning Manager, Prevention and Wellbeing, is going to provide an update on this for us. Emma, are you online there?
Hello, yes, I'm here and play the presentation for us.
Okay, thank you. If you want to go ahead.
Thank you, Jo. So I'm here to talk about the future of care technology within adult social care. And just to tell you about the benefits of care technology, first of all, so it promotes independence, it reduces, delays, or prevents the need for traditional and costly long-term care services, it gives people control over their care, it supports people's well-being, and it allows people to live fulfilled lives at home for longer. Next slide, please. So what do we mean by care technology? It's monitoring, alert and smart equipment and includes apps like Brain in Hand, which is a digital self-management support system for people who need help remembering things, making decisions, planning, or managing anxiety. It includes devices like Alexa, which is a smart speaker that can not only play music, but it can interact with other smart devices and turn on lights or the heating with a voice command. It includes medication dispensers that can help people take the right medication at the right time of day. And it also includes epilepsy detectors, which can alert a carer if someone is having a seizure. And then there are wearable devices like smartwatches and Oyster phones, which use GPS to track a person's location and can detect falls. Technology has advanced greatly in the last few years, and my own smartwatch can monitor my blood oxygen levels and it can take ECG recordings. Next slide, please. So as you've seen in our report, Hampshire County Council and PA Consulting conducted an options appraisal on our care technology model. And they considered 3 options. The first was a current service, which offers a limited range of equipment, with the majority being pendant alarms and falls detectors. The offer is mainly for older people, with care technology being provided in addition to a package of care. The second option was to extend and enhance our care technology offer. This would provide more support to younger adults with learning disabilities. It would also provide a more consistent use of technology solutions for cases with greater complexity, using GPS devices, for example. The third option was to mainstream care technology across adult social care and make full use of the range of technology in the market. It would support both younger and older adults across all needs and service areas. The care technology solutions would prevent, reduce, or delay the need for costly care services. Next slide. So what could this mean for people living in BCP? So this is an example of someone like George. So George is 76 and he lives alone. Until recently, he's been fiercely independent and socially active in his local community. But unfortunately, his health has recently declined, and that's put him at risk of increased risk of falls, which has reduced his confidence. He no longer goes out to see friends in the local area. His daughters live far away, and whilst they visit while they can, they're concerned about his safety and are in discussions with the council about the provision of a package of care. Next slide, please. So how could care technology help George? So today, we would provide a pendant alarm or a falls detector to support him. We would provide a package of care to support him with the tasks whilst he remains isolated at home. And this would be a costly service for the council and wouldn't necessarily increase his independence. So what could the service do tomorrow? So an enhanced care technology service could provide George with a multifunctional GPS device with built-in falls detection. That could alert George's daughters if he goes outside an agreed safe zone. It would also allow George to summon help if needed when he's out and about or if he falls. It would give George increased confidence to access his community, and there would be no immediate need for a package of care. But a transformed care technology service could provide a series of digitally connected devices, including smart socks and heart rate monitors, that could predict the likelihood of a fall before it happens. It could connect George to his daughters digitally and give him back his independence. The system-wide benefits and cost savings would be automatically calculated. Next slide, please. So here's another case study. So this is a real-world example. And here we have Tom. So he's got epilepsy, which puts him at risk when he goes out. He goes to college 3 times a week by taxi, and his carer manages his medication, and he's not always aware if he has had a seizure in the night. Sometimes Tom can seem exhausted and vacant in the mornings, and his carer worries that he may be vulnerable if he goes out unaccompanied. Tom, however, wants to increase his independence. The technology solution was to give Tom the Brain in Hand app, which helps him to plan and catch a bus instead of a taxi. He now has an epilepsy sensor, which alerts his carer when he has a seizure, and it can identify patterns. He now self-manages his medication using a medication dispenser, and he has an Oyster device to give him confidence when going out. And the result of this was a £400 a week saving in care costs, along with a £60 per week saving on taxi costs, And the outcome for Tom was that he got the independence that he wanted. We'll move on to the next case study. So this one shows how technology can be used to ensure safety and to monitor changing needs. So Mary is 62 and she lives alone. She's had a series of strokes and now experiences memory loss and confusion. Her carers have raised concerns about her leaving the house half-dressed without her shoes, sometimes in the early hours of the morning. The technology solution for Mary was an Oyster GPS device to track her movements. The Oyster recorded Mary's movements for 6 months and found that she had walked with purpose on 12 occasions, covering a vast area and sometimes along a major A road. The device allowed family members, and when necessary the police, to be alerted of her location to ensure she could be returned to safety. The GPS data provided evidence that the risk to Mary's safety was increasing, and an emergency placement was arranged whilst relevant parties considered permanent residency. The technology was crucial in helping Mary to remain safe and also in gathering evidence to assess her changing needs. So now we've got a couple of videos to show you. We're not going to show the full video. We'll show a clip of it, but we'll send you the links afterwards so you can watch them in full. And the first one is Peter's story.
So Peter, how has telecare helped you to stay at home independently?
Oh, it's amazing because before you were involved, I went through a stage of falling over.
That's right.
And I got really worried about going out because of falling over and not being able to call anyone.
That's right.
When you suggested telecare, I thought, how excellent.
That's great to hear.
So it's changed my life completely. And I really would encourage anyone like myself to use the Oyster, giving me the encouragement to carry on living a normal life.
That's lovely. And what has it encouraged?
Thanks, Joe. So the next video is Liam's story.
Well, Liam was born with what they call central alveolar hyperventilation syndrome, CCHS. So when he goes to sleep, he doesn't breathe. So you're relying on a ventilator to keep him alive. On top of that, he also has full colonic Hirschsprung's disease, which means he lost a large part of his bowel and has to have an ileostomy. And then the third part was that he also had neuroblastoma, so he had childhood cancer. And on top of all of that, you also have issues related to the development of his brain, so he attends a special needs school. You're dealing with it day by day, 365 days a year, and we've done it now for 17 years.
We've been involved with Hampshire County Council for about 18 months now under the My Life, My Way. It was quite clear that the basis of the My Life, My Way wasn't looking at a person as a disabled person anymore. They were saying, yes, they have disabilities, this is what we need to support the disability element, but on the other side, they have abilities, and each one is unique. So you need to tailor the solution to the individual. As part of that, we were asked to trial the Argente range of equipment. We started with the installation of the monitor. Basically, it's a Wi-Fi connected monitor that allows you to move around freely throughout the house and still be able to see what's going on in Liam's room. It's a two-way audio, so you can hear what's going on in the room. So if he was on his machine, for example, and his ventilator started to alarm, you may not necessarily hear it throughout the house in the normal manner, but the fact that this thing's with you and the speaker's switched on, you would. If he's sat in his room, you can actually talk to him.
Don't forget to take your drugs, Lee.
With it being colour as well, one of the things with Liam is you look at his facial colouring and that gives you an indication of how he is. They also at the same time fitted the bed monitor, the idea being that should Liam be having a fit, his movement through the mattress to the control device will be sufficient to set the alarm off. And then on top of that, we then add the Oyster. You would call it a one-stop shop. Everything is in one little device, and one button push brings a massive amount of assistance.
We've now got to the point where we've been given something that enables us to do what we've been wanting to do for years, which is to allow Liam to have a level of independence on his own without us. Whereas everything before, everything we've ever done with him has had to involve us because we're the backup. Now, the Oyster's the backup, so that we can back off a bit, send him out with a carer, and like he's going out with his sister and brother bowling with his carer. Now that's the first time we've ever been able to do that and us to be detached from it all. So we're going to wonder what to do with those 6 hours on our own, whether we go for a coffee or not, because it's not something we get to do. Actually, when I look at these.
So I hope that shows you the real impact that care technology can have on people, not only the people using the technology, but their carers as well. So I'd like to invite you to ask any questions, and hopefully myself and Joe O'Connell will be able to help answer them.
Thank you, Emma. Councillor Jones, I believe you've got a question.
Yeah, thank you, Chair. Yeah, fantastic presentation. It's really heartwarming to see how technology is really helping so many people and obviously families as well. I just wondered, sort of moving forward, what sort of funding streams and resources were available to keep developing this technology, to obviously to keep ahead of the game and to help more people moving forward.
I'll let Joe answer that one.
So, I mean, there are lots of companies. I mean, we work with PA Consulting and Hampshire, and they've obviously been partners together working on this. And that just gives us one option about how we might take this technology forward if we get approval to take, to move forward, and transform services in the way that we really want to. But there are other options, other providers out there that do a lot of this specialist kit. And also we've been working with our Smart Places team locally, because they're linked in with lots of really innovative companies locally that would jump at the chance to work with us and look at some really interesting care tech options to really help transform services and work with us locally. So I think this does get agreed and gets the support of both Rotary and Scrutiny, and then on to Cabinet and their full support. Then we will then do that next detailed work, is look into the market, say, well, who is it we partner with? And doing that sort of further work to say, how do we drive this forward once we know we've got that sort of funding in place to make it happen.
Yeah, I mean, the technology is actually incredible, isn't it? I mean, it's mind-blowing, to see what difference it can actually make, not just to those that need it, but their families and obviously carers and so on and so forth. So I think obviously anything we can keep doing to move this forward, to make to continue to make a real difference is, just got to do it, haven't we, really? But thank you.
Thank you. Yeah, just to add, I think some of that stuff, some of the kit there today is actually using technology which a lot of us are using anyway. A lot of this technology is stuff that maybe they're simplified versions of stuff, but we all use our mobile phones, and we all use, a lot of us use Alexas now in our house. But it's actually, how can you use technology that's available now to support people to be more independent? And I think that's what Hampshire have been looking at, as well as some of the very specialist kit, but also some of the things that we've all come to learn and live within our daily lives to make lives a bit more easier for us.
Yeah, I must admit, I never thought of Alexa being used like that, but great to see.
Phil, did you want to come in on that?
Yeah, thanks, Chair. I just wanted to add to what Joe said. So nationally, there are there's some funding that's becoming available for those councils and health partners who want to really drive technology forward. So it's quite likely that if we sign up to this, that we can then start to engage in these wider national programs that are pushing some of the boundaries around technology. Hampshire are one of the leading authorities in the country, and they're really going for it. And we've got some catching up to do, but this is our opportunity, and it's really I mean, Emma's been involved in this for quite a few months now, but it's really exciting when you start to see the potential that we've got. That it's, if we break out of some of the traditional boundaries that we've had around us and really just embrace the technology, it doesn't take away care where personal care is needed, but it actually frees up the workforce that might be engaged in the more mundane tasks, or the repetitive tasks such as medication prompts or just pop-in visits, to allow them to focus on those people that have the more complex care needs. So it's a win-win if we look at it in that context as well. Thank you, Chair.
Thank you. Councillor Matthews.
Thanks, Chair. Thanks, Emma. Great presentation. I'm a huge fan of assistive technology. I think the potential that it has is immense, and ultimately it's about empowering people, and that's what we're all about. So I think I'm convinced of its benefits totally. Phil kind of made the point that I was going to raise. It's not a one model fits all. I think that's the one caveat, because there are some people who clearly require more intensive care and stuff. But in terms of creating independence, particularly for younger people, because what I really like about these products is they look really savvy and they look cool. So some of the original assistive technology, it just marks you as different, and I think this blends in. I think that's really important to do that. One question I was going to ask, and touching on the point that Andy made, really, in terms of, it's the kind of ongoing maintenance of the technology. That's also, if somebody has something and it goes wrong and stuff, you know, is that kind of factored into it because of the sort of upgrading and stuff? But I think the potential for this is absolutely immense, and I fully support it.
Thank you, Joe. Did you want to come in on that?
Yeah, so in the financial model that's been undertaken, we've built into that the costs associated with the ongoing maintenance, repairs of that. We've PA consultant providers work around understanding what the lifespan cycle of that is, so we can build that in. And we've also been building into it the additional costs we expect, because there will be the transfer from analog to digital, and a lot of these systems currently work on an analog system, of course. So within the financial modelling, we take into account those factors around, you know, the increased cost of equipment, and a lot of those increased costs we see in this proposal are about the kit. It's about really making sure we've got that range of kit there. It's not so much about staffing, although of course we will need some additional staffing, some additional staff to deal with the assessments, and some to deal with the going out and supporting with the repairs and the monitoring stuff. But most of it's on getting the right kit in and covering that cost.
Sorry, Councillor John, can I just follow on from that a second? I know at the moment that we loan equipment to people. We give them a stool to sit in the shower, we give them a Zimmer frame, etc. So in the future, perhaps we would give them an Alexa to prompt them to take their medication, or whatever instructions you put on it. Oh, sorry, there are other systems available. But now we loan the trolley, the Zimmer frame, free to people, and then when they don't need it, they hand it back. So how much will people be getting of this assistive technology, or is it going to be for self-funders? Is it likely just to be information about what's on the market, or will they be allowed to have some of this stuff as well on loan?
So the modelling and the information the financial information you've been put into this report is around those people that have been assessed as with Care Act as adult social care eligible care needs. But of course, this is an offer we can offer wider to self-funders, and you know, and a service, and working with our housing colleagues who already offer that service. You're right, most equipment items under £1,000 are free of charge to adult social care eligible people with eligible needs, like things like, you know, in terms of those community equipment items. So it would be a similar approach with that in terms of those pieces of kit being loaned to them. But what we'd expect is really around about a set. I think they sort of model it on around trying to a recycling model around about 70 to 80% of the equipment that we would loan out would come back and be reissued. On average, we'd expect someone to use that care technology for around about 18 months of their life, and that's taking into account the large proportion of older people using this service. And then typically most pieces of kit on average last between sort of 3 and 5 years. So we'd expect that equipment went out on loan, came back in and was reissued at least 2, maybe 3 times in the lifespan of that piece of equipment. Now, of course, certain items would be a one-time issue only. You'd only want to issue an enuresis pad to go under someone's mattress to one person. You wouldn't really want to then reissue that. But where we can, of course, the modelling has been designed on recycling this kit and keeping it going. But then over time, similar to our community equipment services work, you work with the providers to identify which pieces of kit are joined towards their end. Do we want to continue with that kit? No, actually, this is the next level of technology coming in, and how do we slowly wind that one down and bring in new ones? So you're always staying ahead of the game in terms of keeping, so you don't end up with lots of old stock in the place, which actually it's got a bit out is no longer as good as some of the new kit that's coming out.
Yeah, Councillor Johnson.
Thank you, Chair. Thank you both. I think this is wonderful and I think it's brilliant and it's the way to go. My worry would be data protection and, people being targeted for things like new mattresses and, like you are now with Google, vulnerable people being targeted by companies for stuff. Is it, how is it all protected?
Joe, did you want to take that one?
Sorry, I suppose that's out there now, isn't it? There's lots of adverts and marketing done for all types of equipment to support people who have a level of vulnerability. Obviously, we would be this would be a service that is provided by the council, and we'd be working with strategic partners and companies to deliver that offer. And the information, of course, we'd be protecting as we would of any other service we provide to our existing clients. I'm trying to fully understand what your concern is around.
I'm thinking like now when we go onto our computers, the data's collected and little adverts pop up that are relevant to sites that we visited. And I'm thinking about whoever it is. I don't understand it all, but I'm aware that whichever company is providing this equipment will probably want to amass the data that they're collecting from it and understand people's situations, and then they could be vulnerable to targeting and advertising for things that they don't want.
Okay, so whoever we do work with, and that we will be ensuring that the service they provided is bound by, in terms of it's there to deliver a service to somebody. It's not there for them to use to sell on the data they harvest from providing that service. So across all of our contracts currently, we'll have very strict rules around, this is our data, these are our customers, you are providing a service on behalf, and these are the conditions we expect you to comply with under the Data Protection Act, for example. So we would be applying the same rigour to whoever we work with moving forward on this, as we already do to any of our care companies that deliver the support to the people, adult social care people.
Thank you, that's very reassuring, thank you.
Councillor Trent, did you have a question?
Yeah, I echo the last point about data and also online security. And, if someone's life is being governed through an Alexa link, then there's things that you could possibly end up bringing into effect on Alexa by just saying the wrong thing. And certainly I know how easy it is to start getting targeted. But the main question I wanted to ask is that it's a great idea if someone's connected, but I think there's up to about a third of our population that aren't connected at all. And I wonder whether any help would be given to those who would benefit from that kind of service to get them connected, whether that's actually part of the calculations.
Who wanted to answer that? I think the question was that a lot of our population are not connected to an internet. So how would they get help with some of these ones that need to use the internet? Phil, did you want to come in on that?
Sorry, yes, I will do, Chair. And whilst I haven't got the complete answer, Councillor Trent, so we can go away and check that out. But it's long been one of the things that's been done that if someone needed a monitoring unit now and they didn't have a telephone line, then we would enable them to get a telephone line in. So the same principle, in my opinion, applies to this. And smart places, was referenced earlier, can, as it spreads out across BCP, can provide that network link. And part of the benefit of that is getting it at low cost, and or at times, is there a way that we can get it at nil cost, and can we access benefits for people that enable them to access some of the services where they may not have the means? But in some ways, there's some very cheap internet provision now that would operate this kit, and we just need to explore those options as well. But I think if committee will bear with us, we'll go away and just check that the connections for people who don't currently have it are included within the costings. But I don't see that as a great barrier to us enabling it. If you think about the cost of an hour's worth of care, that's probably equivalent to a month's worth of it. We wouldn't have to do very much in order to recover that cost and just factor it in. So we'll check that out and we'll inform committee post meeting, if that's okay with everyone. Thanks, Chair.
Is that okay for you? Yeah. Sorry, could I just ask a question? On page 100, you mentioned different items that you had, and some of them are fairly self-explanatory. But can you tell me what a canary is, please? I presume it's not a real bird that you give them.
I'm not sure if Emma, you can see me. Did you want to take that, or shall I?
No, you can take it, Joe.
Okay, so Canary is with a couple of systems. One's called Just Check-In. Canary is another system. They're systems that you put into someone's home to actually, for a short-term period only, to monitor them, to see how that person interacts if they're left alone. So if you, let's say, you've got concern that somebody might, when left to their own devices, sit in that chair and not move, then you can put a canary system in just to see whether or not, well, how much does that person get up? Do they go from the living room into their kitchen? Hang on, we put a sensor on the kitchen, their fridge. Did they open their fridge? How many times have they gone to the fridge? So that might indicate, have they made themselves a drink? You know, have they, things. So it's ways of remote monitoring and understanding someone's movements. And we can do that not only for that, but also at night time to see whether somebody gets up and wanders during the night and get a sense of what's this person doing over that little period of time. And you can also tag it, so it also monitors what's happening with regards to the care staff. Now, often we have care staff working with some individuals on a 24/7 hour basis because we think that's what that person needs, because we're worried about them getting out of bed at night. We put the system in, we find out the person sleeps solidly 7 hours a night, and the carer, who's supposed to be going up and checking them every hour, isn't, and things like this. I'm not saying that's okay, but it would enable us to do that sort of analysis around a person's behaviours, and it helps us then to review the care package and say, have we got this right? Do we need to look at this? So Canary Just Check-In are really useful ways of us putting in, when we perhaps move something around, getting a sense of how that works.
Thank you for that explanation.
No worries,
yes.
but it doesn't have feathers.
No. Did I see Councillor Butler? Did you have a question?
Yeah, I've got two really. One was with the Oyster GPS tracker. If you've got someone with dementia, is this worn on the person, or how would they remember to have it with them, or whatever, if they're going to go off for a walk outside somewhere? I just wondered how that worked. That's the first question. And the other one was, how would people get on if they've got sight and hearing problems with all these devices that are usually quite small?
Emma, are you taking that one?
Yes, so the Oyster device. So the Oyster device, it's quite small. It's smaller than a mobile phone, and it comes with a band that you can wear around the neck. So you often see people will be wearing them around the neck like you would a pendant, but it could also be put in the pocket, or it could also be attached as well to a belt. So there's various different ways it can be worn, and it also has Braille on it. So it's designed so that it's got very few buttons, so it's really easy to use, and the buttons have Braille as well. So it's for people that are with sight problems.
And I mean, a lot of people aren't actually blind, but you know, they can't see detailed print or whatever. But the other part of the question was for a person with dementia. How are they going to remember to actually have the gadget with them?
And that's where I think it comes down to when a person's assessed for care technology, it really comes down to their individual need, and it will be assessed on the basis of that. So someone with very high forms of dementia, it might not be suitable for them. It would need to be for somebody that was able to wear it and able to use it. But it's a lot simpler device, and it's a lot easier than, say, using a mobile phone. So people with mild dementia who might not be able to use a phone to call for help may be able to wear the Oyster device and just press that one button that's on there to do so. So it really makes it more accessible. But yeah, once you get onto higher levels of dementia, it might be that this type of technology might not be suitable, and there might be something else that would be better.
I was just coming back on to what you were saying there, Emma. The issue with this technology is that it is person-centered, isn't it? So as you rightly say, that for some people it wouldn't be appropriate with dementia and stuff. And actually just thinking about that, so some people mention things like Alexa and stuff. For some people with certain types of dementia, audiovisual hallucinations, Alexa just wouldn't work. So it's down to it's being tailor-made, isn't it, essentially, to what is appropriate for the individual. But going back to the point that Councillor Butler made about how do people with dementia realise, remember their phone and stuff, that's kind of how it joins up work with other people comes in. So you have dementia-friendly signage to sort of remind people that, and social cues and stuff around the place. So it's all those kind of things. So, for example, a classic thing in my previous job, people used to forget where they kept their cups and saucers. So we used to put dementia-friendly signage on the facilities. And so it's things like that, sort of joins up things that you can use. So.
I would just say, I mean, we've obviously given some examples of technology, Oyster being one of them, and actually another. There's a plethora of items out there where maybe wearable watches. I know of a case where we worked with a young woman with autism who did want to use an electric wearable device to help them when they were out in the community, but she couldn't stand the feeling of anything touching the skin. So what we helped with is actually designed to have that same technology built into a badge that she could wear on a jacket. It enabled that wearable technology to still be there to support her, so that people knew where, but it actually was not something that was on the items of clothing. So you could be in this scenario looking at something, again, with all the right decisions that you take on best into that individual. If you know that person, if they are likely to remember, always grabs that same coat, always picks up that handbag and takes out that part of their individual. So okay, how could we make sure that where that technology is built into that bag or in the pocket of that coat, there's something there that enables that more information. So you're not relying on her to remember, it's kind of that we know what their habits are, how they put the coat with them.
Thank you. Did anybody have any views on the different options that we were given? Because, I mean, option one being what it is at the moment, which is fairly basic, because we are asked to support the recommendation for the full service transformation. So I don't know if anybody sort of thought perhaps no, perhaps we should go for option two, or does everybody support option three there, the full service? Yeah. Councillor Dedman? Sorry, Leslie, just one moment. Apparently they can't hear us online. Can you hear us now? Yep. Sorry, Leslie, they couldn't hear you. Do you want to try a different one?
Fred, we still can't hear Councillor Deadman.
Sticking with option one.
Okay.
Can you hear me on?
Just check. Okay, so this one's working.
Emma, can you hear us?
I can now.
We've got some microphones that are working and some that aren't. So we're just going to have a fiddle around and see if we're sat in front of one that works. Councillor Rampton's got a comment to make. Can you hear Councillor Rampton?
No.
Hello, that was working, isn't it?
Yeah.
Can you hear me now? That's good, because I just wanted to say something, Chair, that was very complimentary, so I'm glad they can actually hear. And it's just that that was a really, really good presentation, and I'm just so impressed. I think this is one of the most exciting things that we're doing in the council at the moment, and the knowledge that Emma and Joe and Phil have, and others of course, is phenomenal. And I was quite affected by seeing that video and seeing the impact that it had on those carers of Liam, wasn't it? And the fact that they had 24/7 backup because of this technology, and I think that is just incredible. And the other thing to remember is when we're building, as we're going to build our extra care units, we can build in this technology right at the beginning. So it's going, we can train people, we can support people to use it, and it will become embedded. It's not going to happen overnight, but we've started the journey, and I absolutely would think that option 3 would be the way to go. Not that I'm preempting anything, Chair, but I think it needs a radical. We're behind the curve, and we need a radical shift. And I think the work that's being done is just incredibly. I keep using the word exciting. Can't think of another word, but it is genuinely. Thank you.
Can you hear this? Yeah. I was just, because I'm always very cautious with things like this, I was just wondering whether option 2 would allow almost like a trial to see how it went for some people, and then roll out the whole lot later. But that's just being very cautious in a financially unstable world at the moment. But that's just what occurred to me, because it is quite a big thing. But it's all these gadgets are really wonderful, and a lot of them are things that we've never seen. So that's just my comment. Thank you.
Phil, did you want to come in on Councillor Butler's comment there?
If I may, and I can understand the sense of it, of sort of trialing it, but option 2 wouldn't be really trialing all of the new equipment or the approach that we've talked about tonight. It would be just trying to get more users and expanding slightly the range of kit we've got. So I don't think it would transform the face of care, and it wouldn't address the workforce issues that underlie some of the benefits of this either. So I think personally, I would recommend to members to say, let's go for it. Let's really look to transform. Let's look to make this one of the approaches and the cultural approach that our practitioners take at the assessment stage, to really say, would technology help this person remain more independent than they would if we wrapped a lot of care around them? Do they need it to complement the care so that they still get the personal care, but technology helps them when that care is not there? Let's not forget, for the majority of people, the care is only there for 2 or 3 hours a day in total. The other 20, 21 hours, they're on their own potentially, or just with, maybe a family member. So think about the wider benefits of this rather than just the technology maybe thinking it's all kit and it might get in the way of someone. It won't get in the way. It actually opens up people's lives. That's what we're really trying to do here.
Councillor Jones, was that the comment on that? Because I know Councillor Kelly there wants to come.
Yeah, I just want to echo really what Phil said and what Councillor Ramsey said earlier on. A fantastic presentation, really exciting, great to see all this technology. I just think we need to be bold and go for option 3. I really do.
Yeah, I don't know if you can hear me, but absolutely agree with that last comment. And I think I would hate to see somebody who could benefit from this miss out on having the opportunity. So I'm convinced, go for it.
Councillor Kelly, did you want to add anything?
If I'm allowed to, really good to say something about this in terms of our priorities for enabling people to be resilient, to do things for themselves, to be able to contribute in their lives, because I think many people with disabilities, or as people get older, they're not able to do things other than just kind of exist, really. And anything that enables them and make them feel useful, part of a community, it's so good for their health, their well-being, that they feel that they're doing something to help themselves, which is brilliant. So I'm all for option 3. Thank you.
Thank you. So is the majority of the committee then saying that we recommend to Cabinet we go to option 3? Yes? Okay, yeah. So thank you for that presentation, and I think it'll be something that will be coming back later to us as well, sort of as technology progresses. Sort of it will be sort of interesting in the future when we're all sat there with our smart watches and doing all sorts of things with it. Can I move on to agenda item 9, the BCP carers strategy? So Emma, you're going to do an update on this. We have had a lot of background work on this, so you know, I think it's just an update as to where it's going, because we're asked to support the recommendation to approve it for the Cabinet. So Emma, did you want to carry?
Yes, thank you. So yeah, and thank you to the committee for all your support with the carers strategy. You've been there through the beginning, from when we first went out to carers, and you helped with the survey that we sent out. So thank you for that. Where we are now then with the BCP carers strategy is that it's going to Cabinet in 2 days' time. And we've got Councillor Lawrence Fear here with us as well, the lead member for Wellbeing, who wanted to say a few words on it too. So I'll hand over to Councillor Fear.
Sorry, we can't hear you. We've lost you completely, Councillor Fear.
Can you hear me now at all?
I can hear you.
Is that better?
Yeah,
Lovely.
that is.
Sorry about that. Yeah, so thank you very much, Chair, for letting me just speak a few words on this paper. It's been a long time in the making. Obviously, all members on this committee know, and the work you've been doing as well, and this has been amazing. I think, you know, from where we've started to where we are now, it's fantastic. You know, having the 5 points of identifying, recognising the involvement of where we're going with things, how we're delivering on the information and advice, the lifelong caring situation that we have, the inclusion and promotion of young carers, and how moving forward we will be able to support them, and how we change and improve our information delivery for carers. I know I'm just doing a short overview, but I feel like after to getting to this point now, after all the oversight that you have done as a committee, all the work that the carers have done and the officers, it's nice to have that little 10-20 seconds of reflection on where we've come from, and obviously going through this process as well, we're aware of the multi-layered view we've taken when we're going through this process, and that's why I'm very pleased that we have had a crossover of supporting carers, not only physical but mental and emotional well-being, and also going through this process that we've had the carers lead at every term, and we've dedicated ourselves as a local authority going forward to be a proactive authority, not a reactionary one. And what do I mean by that? I mean, and you'll see this in the papers, and obviously I'm going to be able to clarify this as well, but it's us as an authority going out to carers, offering the support, letting them know we're there instead of carers coming to us. And, you know, by doing that, we are being on the front foot with this. And I think as well, it's important of how we've listened to carers through this whole process on the care freedom for carers. What they do is unbelievably amazing, and supporting them in that role, but not just leaving it there, but everything else that impacts their lives and how we can support them outside a caring role is just as important. So I'd just like to finish, Chair, by saying this paper was made for carers, it was made by carers, alongside the fantastic officers with Emma and Tim Branson and others. All of you on this committee have been amazing, and your thoughts and views being fed into this, and obviously are mostly carers that have taken the time and been really part of this process. So I'd just like to thank everyone involved, and I'll pass back to Emma to clarify any other points that the board may have. Thank you very much.
Thank you. So it's just really, if anyone has any other questions, you've all had sight of the strategy. It's going to cabinet in 2 days. So if there's any kind of final points really from anybody.
Thank you, Emma. I would like to emphasise that carers are often overlooked and not really recognised for the work they do, looking after a great number of vulnerable people. And they do it either for no pay or for very, very little pay on a carer's allowance. So I think that, you know, we really need to thank them because they take a lot of work off our services and the NHS and all sorts of people. So I think this is brilliant that we've got this strategy for them. But I would like to ask something about a financial implication. You mentioned about the Better Care Fund, in that you're having to increase the number of staff, and this could be at the expense of respite care for some of the carers. So I think I would probably speak for most people here, if not everybody here, that we really need the government to recognise respite care, the Better Care funding for our carers. And, you know, and I think we need to push that this funding needs to be maintained and, if possible, increased to help these people, because it's a thankless job in a lot of cases, looking after some of, especially someone with advanced dementia or something. And of course, a lot of these carers, if it's their partner, are the same age. So some of them are, you know, sort of older as well. So I hope that, you know, that we don't lose too much respite care for some of these carers, and that we can push where we can to get this government funding in the right places for these people out there. So has anybody got any comments or questions on the strategy? No? Councillor Evans.
Thank you. I think this one's working okay. Yes, such a brilliant piece of work. I'm hugely excited that it's going to Cabinet very, very shortly for approval. Just thing I wanted to raise was we had discussions earlier about terminology for carers and a better term than unpaid or that sort of thing for carers. We're thinking maybe recognised carers. I didn't see that in the strategy. I was just wondering if you could comment on that, please, Emma.
Yeah, sure. So when we got the final survey results, so 30% of carers said they liked the term recognised carer, but 28% of carers said they liked the term unpaid carer. So it was really close. So we took that to our focus groups to have a conversation with them about, you know, what they thought about that. And a lot of carers said the reason they picked recognised carer wasn't necessarily about the term that they wanted to see written down. Is it that they just wanted to be recognised? And that's why recognition is one of our key priorities for the strategy. What they said was that where there's a term for carer, they don't want a different term being used at the hospital, a different term being used when they go to the GP, and another one again when they speak to their local authority. So there was a bit of reluctance to kind of change the term that we use completely, which is why I've kind of stuck with just carers in the strategy, because sometimes the term unpaid confuses carers as well. Some of them said to us, well, actually, if I get carers allowance, does that mean that it doesn't include me? Because I do essentially get paid for caring. So using the term carers and then including that definition of what a carer is at the beginning was deemed to be the best way forward. But I think by doing that survey and understanding that carers want to be recognised, that was a really key part of it, and that informed the priorities.
Yeah. Anybody else? No? So do we recommend support of the strategy for the Cabinet? Yes? Okay, lovely. Moving on to agenda item 10, the CQC assurance process. So, Jo, I think you're taking this, aren't you?
Okay, thank you, Chair. Thank you, members, for giving me this opportunity just to really give you a briefing, really, of what's around the corner for us in terms of the new adult social care assurance process that the Care Quality Commission will be introducing. So, just a bit of background on this is there are some very sort of challenging programmes in mandatory and legislative transformation that are hitting adult social care over the coming years. We've had the Health and Care Act in 2022, which has formalised the integrated care system. We've had the people at the heart of the care paper, its new vision of adult social care and how it's doing person-centred care for people. And that includes the new CQC assurance programme and the charging reforms, which are the delay part of the of Care Act in 2014 that are due to come in from October 2023. So this is just to really focus on the new duty for the Care Quality Commission and how it assesses local authority performance in delivering their adult social care duties. So underpinning this new assurance process, we have, as I said, the people at the heart of care, the 10-year vision around personal care for services, around having choice, control, and supporting people to live their independent lives, how people can access outstanding, good quality, tailored care and support, and that they find adult social care fair and accessible. And then at the bottom there, we've obviously got our ongoing need to ensure that we are complying with the Care Act from 2014 in terms of prevention and delaying and getting people the right information to make decisions, and again that aspects around people receiving high quality services and that element of choice. So those both feed into this assurance programme, and really what is by any other way an inspection process by the Care Quality Commission, and what they have made clear is it's going to be covered under 4 themes. They'll do that assurance process looking at 4 themes. One around working with people, one about how we provide support, how we ensure safety, and our leadership as in terms of our thing. And they'll pull on the evidence from people's experiences, feedback from ourselves and our partners, working with our staff, and obviously working with leaders within the organisation by observing our practices, looking at our processes, and looking at our outcomes and performance data to get that view of how is BCP performing. So what do we know so far? Well, inspections are due to begin in April 2023, but it could take 2 years for them to sort of continue to do that first wave of assurance visits. And so we're not really expecting whether or not they might use that first 2 years as a benchmarking exercise to get a full picture of how the country is doing before they introduce a kind of a grading system for in terms of the way that they sort of pass the judgments on local authorities. Their local authorities are currently, we've been working to a draft framework. I think we are imminently about to get the final framework. We've had information from CQC that it's now with the Secretary of State to make final decision before it's published. So we're pretty sure that very soon we'll have a final version of a new framework to work to. We're still not sure whether or not there'll be a self-assessment tool that CQC themselves will produce, but we are working with our Southwest regional colleagues through ADAS as part of the sub-regional working group around developing a self-assessment tool that we can use to help us prepare. What we do know is that when inspectors do arrive, they will already have a great deal of information about BCP by looking at all what is already published and what those challenges are to then coming and then sort of then do that in-depth work with us. So they'll come sort of armed and ready to go. So this new thing, what we do know about the single assessment framework, it is sort of 5 sort of key bits. One, the top bit being the 5 key questions that they'll ask around those areas which are in the form of I statements based on what people expect from services. Then around quality statements that we've developed as local authorities and with the integrated care system about how we measure the quality of our services, the evidence in terms of people's experience, feedback from surveys, feedback from working with staff, feedback from our partners and what they observe, and then the data that they get, the metrics they get from in terms of returns that we already apply information there, that sort of quantitative data that they'll be looking at. So what do we know around the scope of what they'll be looking at in their assessment of local authority functions? Under that, working with people, this is about really understanding how we assess people and review their needs, including carers, and the importance of those, how we're supporting people to live healthier lives, where we are on our prevention journey, and just heard tonight about our care technology approach there, big part of our prevention journey and how we're supporting wellbeing, and our information and advice offer. What that would then mean in terms of their move on to providing support. This looks very much around our commissioning activity and our sufficiency. Do we have the right care within the market at the moment? And we know the challenges that we are facing around that at the moment. But is it sufficient? Is it affordable? And is it diverse enough to meet the local needs of our population? And how well are we effectively working in partnership as an ITF to deliver that care and support? Ensuring safety obviously has that big focus on our safeguarding, safe systems, and our processes for managing that, with a particular focus around how we support young people in transition and other transitions in life, and that continuity of care approach. And then as a leadership team, how we are, as leaders, are working as compassionate, capable leaders, that we've got sound governance in the terms of how we make decisions, and that we can track those decisions through, that how we learn from improvement, how we innovate, and how we promote equality, diversity. So that's the sort of the areas that we'll be assessed against. And as I said, a lot of those will have various I statements that we need to sort of do there, how we make sure that we fulfill our statutory duties, how we focus on choice and care. And then at some point we would be awarded an overall rating. But as I said, that might be not until 2 years down the line, even if we get inspected quite early after April. We'll wait to hear on this. This slide just gives a bit of a sense. It sort of says, okay, how might CQC intervene then, depending on how well we're doing? And that bottom of the tier obviously sort of is around local authorities leading their own improvement. That next level up, if there are some issues, how CQC would work alongside us. And if we're really doing bad, as a last resort, how they might intervene with statutory duties. So it just sets out really the power that CQC has, depending on how we do in that in this process, to how little or how much support they may impose on us or provide us. So as I said before, we're doing a lot of work with our regional ADAS group at the moment, and we have a specific CQC assurance working group that meets, I think it's every other week, it's very, very regular at the moment, to sort of talk through where we are, how we're building together our evidence bank of information in preparation for the assurance program next year, and how we're ensuring that we have that triangulation of evidence, so that when we're not just looking at one thing and telling us this tells us something, we're then looking at another bit of evidence and saying, does that corroborate what we're thinking? And then what do people say? Well, does that corroborate what we've got from our performance indicators and what the other information we have from our staff is telling? So that it all should give us an overall good picture of how well we're doing. So we have a quality board that's been set up internally across adult social care services and commissioning to give us oversight and to help sort of start to gather that information and test and challenge ourselves. Our quality assurance team have been working with our managers and heads of service to gather that information, and so we've got a really good sense of how well we think we're doing on our journey in preparation for CQC. We're in the process of developing a dashboard, and that dashboard will be twofold. One will be all the metrics, all the quantitative data that gives us a sense of how well we're performing in terms of the numbers, but also a dashboard that's all the qualitative data that we know that says how well we're doing in terms, and an evidence bank. So when they do come to us, we just go, here you go, here is our dashboard. In this you can dig as deep as you want to. Here is all the relevant information, whether that's different processes, policies, information from surveys, feedback from audits we've done, etc., to give us that that holistic view of how well we're doing. And then obviously, as part of as we move that forward, we'll be developing a communication plan ahead of April next year. So and on the lead up to sort of help engage key stakeholders in this assurance. And part of the reason why we're here today, talking about it now at this early stage. Next steps are for us is to, this is already underway. So we've got a CQC operational group working specifically with all the managers within adult social care services, and we've now got a similar group established looking at our commissioning activity. It's to continue this preparatory work we've going to do now, and now sounds like we almost get our framework. Finally, we'll be able to test, or we can start looking at that new final version of the framework and checking, are we on the right path with that, to roll out our engagement plan, and then in November we've got a staff engagement session to just introduce us with them and warm them up, to continue the quality board as we move forward, and we'll want to introduce service user involvement into that work, and that would include carers as well, and look to undertaking a self-assessment this autumn. And that's that. I'm happy to take any questions people have around that. I'll just stop sharing.
Thank you, Joe, for that. It's a bit of the unknown, isn't it, almost, that no one's had the inspection yet. So I expect whoever has it first will all be leaping on them, sort of seeing what sort of questions they were asked and everything. So, yeah.
Yeah, there are Hampshire, I think it's Hampshire, there are some authorities that are acting as trailblazers, and I think Hampshire is one of them. So we really do need to nobble them and say, what have you learned? What can you tell us on the back of them being the guinea pigs for some of the CQC's testing out of their new inspection framework, assurance framework.
Thank you. Councillor Jones.
Yeah, thank you, Chair. Just going back to what you were saying about the overall rating and the subcategory ratings which we receive, obviously following the inspector's assessment. If we're not happy with the outcome of either the overall rating or what we're given in the subcategories, how do we go about challenging that? What is the process involved in that?
I suppose we wait to find out. So we expect that when obviously CQC come forward with their final version of their assurance programme, within that there will be, and as we get closer to it, there will be, they will explain how, if we're not happy, we can challenge that. But in other similar, so in Ofsted or anything else, when they come in and do that, we do have the opportunity to respond to those findings and challenge if we think they're inaccuracies or they've got something wrong, or provide additional information if they feel that is. So one would expect there would be a similar process available, but we wait for clarity around what this assurance process will be and how those steps would. So I anticipate there would be that opportunity.
Okay, so you can actually have conversations with the inspectors there. It's not like an arm's length operation where you don't really know what they're thinking or what they're going to say, and then you get a surprise at the end of it.
No, they would descend upon us and they'll be spending time with us in meetings and grilling us for, whether it's a week or 2 weeks, whatever, they'll be with us happens in other inspections similar to Ofsted, etc. So there'll be lots of opportunity for us to put our point across, and I dare say then once we receive a sort of draft from them, the opportunity to comment against that before they make a final view on that. But as I said, I don't know if Phil, you've got your hand up there, so I don't know if Phil's got anything you could add there. Chair, I'm not sure.
Yes, come on. Yes, Phil.
Thank you, Chair. It wasn't the reason I put my hand up, but if I comment first, I think Joe's correct. If it'll be, I would expect, but we don't know. We must wait for the detail, not to make too many assumptions or presumptions, that we will be allowed to challenge on the factual accuracy of the information they play back to us. It's unlikely, unless there's something completely inaccurate, that we'll be able to challenge their judgment of us. And just to say that they are saying it's an assurance process rather than an inspection, but because they're likely to have the ability to intervene or create a level of interventions, then I'm afraid that it's as close to an inspection as an assurance process can be. What I wanted to just say, Chair, is I would expect that this committee wants to be really cited on our self-assessment and our preparations. So I would expect this to be a reasonably regular update to committee, but probably the first update will be after Christmas, So probably around, I just have to work in with the agenda setting. But I think before, if they did turn up in April, I would have liked this committee to be cited on how we view ourselves and what plans we put in place where if we identify something that needs improving. So I guess it was just is that what committee would like, Chair?
I would think that's a good idea, yes, because to put it forward on our forward plan or sort of action plan, really. Yes, just to keep sight of what's happening with this, I think it's a good idea. Anybody else got any questions on this? No, no. Yeah, thank you very much. Thank you, Joe. Thank you, Phil. We move on to agenda item 11, the Health and Wellbeing Board update. So I've got Sam Crowe. Oh yes, I can see Sam. Yes, and Councillor Kelly. So you're going to give us an update, both of you. Is it yes? Does Sam want to go first?
Yes, actually, thank you, Chair. It's Sam's report, really.
Thank you very much. Good evening, Chair. Good evening, members of committee. So it's a verbal update tonight, as I received this sort of fairly short notice, so hopefully that's okay. What I was going to do is just remind committee of the health and wellbeing strategy that's in place that was developed in 2019. Obviously, COVID affected delivery quite significantly over the past couple of years, but we set 3 priority areas for the board's work, which were deliberately quite broad. The first was around empowering communities, and I'll talk about the work that we've been doing through the board to support those priority neighbourhoods. The second priority was around supporting healthy lives, and if you remember, that was designed to run as specific themes over a 15-month period. So we started right at the beginning of the pandemic with raising awareness of mental health support, and that has now finished. So a lot of the local communications that we did, including things like the Light On campaign, were part of that work. We're now entering another 15-month phase, and the theme will be physical activity, and the work of the board is very much about supporting the launch of a new physical activity strategy working with Active Dorset. And then the final priority area was called Support and Challenge, particularly to enable services to work better together. And there's a real mix of issues under that priority. We started off looking at improving support for children with SEND, and there was a strand of work that was about ensuring best outcomes from the local changes to NHS services, not only to do with the clinical services review, but as the local system started to become an integrated care system. And more broadly, just looking at the integration of health and social care, including delivery of the Better Care Fund. So that's how the current strategy has been set up. And I've just got a few key notes on some recent work under those headings, if that's useful for committee. So under the priority neighbourhoods work stream, probably I'd start with the work around access to food partnerships, which has been pretty successful now. They've recently received some 3-year funding under a lottery bid. It's enabled them to continue their work. They've now got a network of perhaps 200 people representing more than 50 organisations who are working together with a mixture of interventions. Partly they've been distributing some of the funding through the Household Support Fund. They're also connecting schools with offers of food support where that's necessary. I think they've managed to reach about 81% of schools so far, so some good numbers in there. And they've also been working on developing the Access to Food map, which has been accessed nearly 50,000 times since it was launched. And that map brings together lots and lots of locations of resources like food banks, community fridges, social supermarkets, community meals, food parcels, community growing projects and cooking workshops. So it's a fantastic resource and looks like it's being widely used. The other element of the work that I was going to bring to committee's attention was in 2021, the Health and Wellbeing Board agreed to support the approach to asset-based community development. We did some work through the board to identify neighbourhoods that fulfilled the criteria of being among the most, or among the 20% of areas most deprived when you look at the nationally produced indices of multiple deprivation. And that gave 9 priority areas across BCP Council. All of those areas have a community development officer in post, and the role of that officer is really to support local people, almost as a facilitator, to start to understand how they can make changes in their life that would better support them, whether this is about helping to set up local activities, particularly connected with things that matter most to people, forming and strengthening connections in those local communities. So we see those officers as playing a really key role as we transition to implementing that strengths-based approach to community development. We've recently agreed, as of today, that we'll step in and support the continued funding for those community development workers. So I'm really pleased that we'll enable to cover the whole of the 9 areas. So it's really important that we see that work through over the next couple of years. There's been quite a lot of work going on, unsurprisingly, about winter resilience. So in July 2022, the communities team, working with members of the Health and Wellbeing Board, held a conference for over 100 frontline workers right across the BCP area, really about raising awareness of what was coming down the track in terms of the cost of living situation, and really to just highlight a range of support that was readily available. What came out of the event was quite interesting because many people said their sources of support. So one of the key outcomes of the event was to provide the attendees with the USB stick, which has all of the information about existing sources of support. And the attendees have taken away pledges to make sure that they're through their networks and their colleagues. So a really useful event, and you know, just part of the preparation that we're trying to do as the cost of living crisis continues to pose challenge. There's another set of proposals that's being developed to support communities with the cost of living situation, and that will run over the winter. There's going to be 5 work streams by the Together We Can steering group, which is still meeting regularly. And the 5 dedicated work streams are around developing a network of warm welcome spaces across BCP Council, a wellbeing network with support to mental wellbeing. There's a fuel and energy work stream. The existing access to food partnership forms the 4th work stream, and then work stream 5 is a cross-cutting communications work stream, which will continue to support the activity. And that activity will be funded from the Household Support Fund Round 3, which is coming in from October the 1st to the 31st of March. Around the promoting healthy lives strategy, I was just going to talk a little bit about the physical activity work that was being done. The strategy was presented in draft to the board in the summer. We've gone with a title that reflects the broad nature of the importance of physical activity. It's going to be called A Movement for Movement. And that was partly because in some of the engagement work, we've recognised that sometimes the language that we use can exclude people. So it's not going to be talking about exercise or sport or any of those other words that are sometimes used by professionals, but just to promote that broad concept of the best thing that you can do is just to move more. There's a comms plan which is being developed, which will be ready for October. We're going to launch it to the integrated care system. So it will come back to the Health and Wellbeing Board around about the 13th of October. It's going through the Dorset Health and Wellbeing Board, but the next phase is the most important, which is then working with both Health and Wellbeing Boards and a range of organisations in the integrated care system to work on the delivery plan, very much looking at what each partner can bring. So the strategy sets the framework. The really exciting bit is then working on the delivery plan as we go forward. And then the final part of the update is connecting to that 3rd priority, which is supporting integration and how we understand how to get services to work better together. You'll be aware the integrated care system went live in July 2022. There's a new integrated care board, and then above the integrated care board and working alongside both health and wellbeing boards is an integrated care partnership. The partnership's first meeting is tomorrow, and some of the work that we've been doing with both health and wellbeing boards has been thinking about their emerging role, particularly around place-based partnerships. So as we transition and as the integrated care system's established, we're looking to position the health and wellbeing boards as the strategic board for each place in the integrated care system. There'll be 2 places, one centred on the BCP Council footprint and one centred on the Dorset Council footprint.
And as the place-based partnerships develop, their role will really be to start to develop commissioning plans, which will be devolved to each place. And we feel that the Health and Wellbeing Board plays a really vital role in making sure that we're able to steer the development of those plans by giving a really clear sight on the emerging priorities, particularly from the Joint Health and Wellbeing Strategy, which in turn is informed by our needs assessment, which remains a statutory requirement of the board. So over time, as those places become increasingly responsible for commissioning and joining up care, I think the boards will have a really important role to play. It's likely that we'll have to refresh the Joint Health and Wellbeing Strategy once we've had the Integrated Care Strategy published in the winter, and that will tie more closely into the Integrated Care Partnership Strategy. But it's also a really good opportunity to start to be more specific in the Joint Health and Wellbeing Strategy about those areas of health and care where we see the greatest potential for integration and improving outcomes, and make sure that we've got a really, really strong place-based voice, getting the best for our residents. So that was all I was going to say by way of the health and wellbeing update tonight. I think the key message for me is that, you know, we are in transition, but we've got a really, really good opportunity through the Health and Wellbeing Board to play a really full role in the integrated care system, and I'd urge partners to continue to support the excellent work that the board's been doing.
Thank you, Sam. There's a lot of information that you gave out there. So has anybody got any questions for Sam? I know I've got one. When you mentioned things, was it the warm banks and the food map and everything like that? Is there a place where we can actually find that so that we can sort of spread the word as well? Is there anything on the BCP Council website that we can sort of, if our residents ask, that we can pinpoint them where to go, all this information?
Yes, there are pages. What I'll do is I'll provide a note to committee after the session's finished with all the links, if that's okay, and I'll work with Kat Macmillan to make sure that the most up-to-date information is available.
That would be really good. Thank you, Sam. Anybody got any questions? No. Thank you for that. I shall look forward to the links. Yes, they'll be very useful.
Thanks very much.
Agenda item 12, portfolio holders update. Councillor Rampton.
Thank you, Chair. Are all the mics working now? Seems to be. Thank you, Chair. And I know you did mention about having a financial briefing from me at this committee, but it's quite difficult to do that at this stage. So we're facing financial pressures driven by the food and electricity, and the council seeing cost increases for care, and obviously for heat and light, and also for construction materials. So Cabinet and CMB are working together on a financial strategy, and the first stage of that is actually coming to Cabinet this Wednesday, and then there'll be a more detailed paper in October, and after that they'll be able to give you more of an update at this committee. We don't know yet what the impact is going to be of the changes, from the Chancellor's announcement the other day. So there were changes mentioned to NI and tax, and of course, as ever, the devil is in the detail. So we're still waiting to get the full detail of that and what the impact could be. I've got a bit of good news, and Councillor Butler might be interested in this because we've spoken before about job centres and how they can help to support and help us recruit people to the care market. And so Job Centre Plus, this is in partnership with Adult Social Care Commissioning, are supporting providers with recruitment events on the 3 Job Centre Plus sites, and that's starting in October. And those sites for Councillor Butler are Cotlands Road, Castle Lane East, and of course the Deer Hay Lane site in Poole. And what they're trying to do is to help remove that stigma around working in the care industry, and to promote the working in it. So they're inviting providers to register and then to come along, and they can bring their promotional materials and their laptops and so on, and then they can speak to individuals who are come in and who might be interested in that role and talk to them about what their particular offer might be for them. And so that's a really positive outcome, and I just want to say thank you to officers and losing my voice in commissioning for doing that hard work with Job Centre. Really look forward to seeing the outcomes from that piece of work. So I haven't really got much more to say, Chair. I'm sure Councillor Kelly's got other updates, but unless there are any questions from me, that's it from me. Thank you. Anybody got any questions for Councillor Hunt? Councillor Evan.
Thank you. Forward plan from a while ago. It was where the Cabinet have written to His Majesty's government, asking for an increase in the national living wage for carers and also an increase in carers allowance. Thank you.
Thank you, Chair. So I was slightly hoping that wouldn't come up because it's a little embarrassing in that it was discussed in Cabinet. We did agree, but we can't actually find the record of agreement which would have triggered that letter being sent. So I could try and pull the wool over your eyes and say, we were waiting for the new government and the new health minister, and then we were going to send it in then, but that isn't strictly true. So it is something that has been picked up, and Louise is already on the case, and it will be done to the new health minister. So apologies that there has been that confusion and that time lag today.
Thank you, Councillor Rampton. Councillor Kelly, have you got an update for us?
Yes, I've got a couple of points. Thank you, Chairman. So just to say that I attended the first Combating Drugs Partnership meeting on the 5th of September. I think members may be aware that it was chaired by the Police and Crime Commissioner, David Sidgwick, and Pan Dorset Group, responsible for overseeing local delivery against the new National Drugs Strategy, which is called Harm to Home. Objectives: to prevent demand for drugs, improve outcomes for people in treatment and recovery, and ensure effective enforcement against criminal gangs responsible for the drug supply lines. To do this, the partnership brings together representatives from health, councils, criminal justice, probation and police, as well as people with lived experience, which I think is really important. The partnership will be supported subgroups working on each of the objectives, and the next meeting in November of this partnership. Also, Chairman and members,
sorry, you cut out a bit there. Can you just go back a couple of sentences?
Oh, did I? Oh, did you get to who is represented in the partnership? Health councils, criminal justice, probation and police, and people with lived experience. The partnership will be supported by subgroups working on each of the objectives, and the next meeting is in November, where it will review the first needs assessment for the partnership. Okay, and the other thing I wanted to just mention, please, is that I've been taking part, along with Sam actually, first Poverty Truth Commission for BCP Council, first one to be set up anywhere on the South Coast. My role is to be one of the civic and business commissioners, and we meet monthly to come together with the community commissioners to hear directly about people's experience of poverty and what more can be done to support people by understanding more about their circumstances and experience with statutory services. I think the Health and Wellbeing Board actually heard from the Commission in the early stages and will receive progresses. Thank you.
Thank you, Councillor Kelly. Has anybody got any questions? No. I think we will certainly like to hear more about sort of the poverty truth sort of one as that progresses. I think that's brilliant that we are the first on the South Coast to do it. So that's really good news. And thank you for taking part in that, Councillor Kelly. So
yeah, it's brilliant. Yeah. Okay.
Thank
you very much.
Okay, thank you. So we move on to the last item, our forward plan. We got any suggestions on or any comments on this? as you know, we've lost one of our meetings, so we're having to sort of squeeze in quite a few agenda items on these. So if you have looked through, if there's anything that you wanted to add to it, we'd have to squeeze it in somehow, but I don't know. It seems fairly comprehensive, all the things that we have brought up and statutory duty that we need to look at here. So no comments. Right, okay then. Thank you very much. Thank you for you all attending in person and those online, and for all the reports and everything that came out, all the hard work involved in that. So I'd like to close the meeting. Thank you.